wonderful speaker. I am so thankful that Bianca reached out to us and wanted to provide a presentation. She is a board certified physician in physical medicine and rehabilitation. And she comes to us from New Jersey and has had experience working with folks that have HSP and PLS. And without further delay, I'm going to go ahead and introduce her, let her take off with her program, and then you guys hold back on the questions until she's ready for that. But if you will, please just welcome me and welcome Bianca for attending today. Thank you, Dr. Martinez. How are you today?
I'm doing well. It's wonderful to see so many faces here. This is terrific. I appreciate you all being here. Alrighty. Well, thank you, Norma, for organizing this. And it's wonderful to see so many faces today on a Saturday. Thank you for your attention and your time. Today, I'm going to be talking about spasticity management. I am a physiatrist. I'm Dr. Bianca Martinez. I'm a physiatrist working at a Girt Physical Medicine and Rehab Associates. Just a little bit about me. I did my residency in physical medicine and rehab in Philadelphia at Moss Rehab in Temple. And during my time there, I met a lot of patients with spasticity due to numerous neurologic conditions. And I saw how it impacted their function, quality of life, but I also saw that it was being undertreated and undermanaged. So I decided I needed to do a fellowship in it, and I did a spasticity management fellowship over at Jefferson, also in Philadelphia. And now I'm really happy to be working in New Jersey at Girt with a really wonderful team. So I'm going to get started. Thank you again. So the outline for today's talk, I'm going to go in order. I'm going to talk about what is spasticity, what are some of the complications that come about because of untreated spasticity, and how does it present in both the upper limb and lower limbs. I'm going to talk about treatment goals. And then finally, I'm going to talk about our toolkit. There are a lot of treatment options available to manage spasticity. And then a few people had questions on certain devices, so I decided to also provide a brief overview of braces that are used in the lower limbs to help us walk better. And then lastly, I'm going to end with future directions. There's a lot of exciting research in spasticity management, and I think it's going to, how we treat it now is very different to how we're going to be treating it in several years from now. And lastly, I'm going to share a patient story and treatment plan that will nicely summarize everything. All right, so first of all, what is spasticity? Spasticity is part of an upper motor neuron injury, and it's defined as exaggerated tendon jerks, but I like to think about it this way. There are two-way tracks that go from our brain to our muscle, and track one is from the primary motor cortex in the brain to the spinal cord, and then to the peripheral nerve muscle, and it tells the muscle to contract. That's kind of like the gas pedal in the car. Track two is like the brakes in the car, and it starts with the sensory nerves located in the muscle spindles, travels up to the spinal cord, connects with the brain, but also relays messages to the muscle and can tell the muscle to relax. So I like to think about spasticity as an issue with the brakes in this system, an issue with track two. And that's why you get these tight muscles that are just going, and they just won't relax. And that gets in the way of movement. So in general, when thinking about ALS and PLS, we see spasticity in both the upper and lower limbs, but in HSP, it typically only affects the lower limbs. So it's going to present very differently depending on the neurologic condition, but that's essentially what spasticity is. The sequela of spasticity. So persistent and untreated spasticity can lead to pain, can lead to contractures, limb and trunk deformity. It can impair the way you move, walk. It can also affect your seating. It makes it more difficult for you to be seated comfortably in a chair or power chair. It can cause skin breakdown in certain places. Can cause difficulty with self-care and hygiene, and it can lead to poor body image if untreated. So I wanted to show some photos of what spasticity, how spasticity can present Now, these are photos taken out of a major paper done on spasticity in the post-stroke population, but these postures are common in anyone with spasticity in the arms. So, starting proximally from the shoulders, you can have spasticity in the shoulder muscles, such as the pectoralis major, and that will cause your shoulder to become adducted, which is when your arm gets stuck to your side. You can have spasticity in the arm muscles, such as the biceps, and that will cause you to have a flexed elbow. You can have your forearm pronated, which is when your palm is facing down and it's difficult to face it up. You can get spasticity in your wrist flexors, and that makes it hard for you to extend your wrist. You can have spasticity in your fingers and your thumb flexors, and ultimately end up with a clenched fist, which makes it difficult for you to passively let go of items, to grasp items, or to maintain cleanliness in the hand. So why is it problematic? When you have tightness in these muscles, we can go, in order. When you have tightness in the chest wall, it's difficult to rate population, but these are all common presentations in all of the patient population groups. So if you have spasticity in your legs, starting proximally and going distally, you can have spasticity and tightness in your inner thigh muscles. So starting from the top left, and that will cause you to have adducted thighs. So that's when your thighs are stuck together. So when you walk, it's hard for you to spread your legs apart and have a wide base of support. You can have spasticity in your hamstring muscles. That causes you to have a flexed knee. You can have spasticity in the quadricep muscles, and that causes you to have that knee in full extension and it's hard to bend it. And then in the ankle, you can have some of the most common postures would be when your ankle is plantar flexed, which is when your foot is pointing down. That is due to spasticity in your calf muscles. You can also have what we call equinovarus, which is when you have spasticity also in the calf muscles, but your foot turns in and you walk on the outside of your foot. You can also have spasticity and tightness in the muscles that control your toes. So you can have an upgoing big toe, you can have toe curling or toe clawing. And tightness in these muscles can be problematic, just as in the upper limb. In the hamstrings, it's going to be difficult for you. If you have tightness in the hamstrings, your knee is flexed. So it's difficult for you to straighten the leg, and you tend to walk a little more crouched. And because you can't straighten the leg, you can't take a long stride. When you have tightness or spasticity in your quadriceps, that's what extends your knee. You walk with what we call a stiff knee gait, and that's very effortful. So it's hard to bend the knee and to have a smooth walking pattern. It's also difficult to be seated comfortably if you have tightness in either the hamstrings or the quadriceps because it's hard to bend and extend your knee. Tightness in the calf muscles can cause that drop foot or that equinus posture. And with that, it's difficult you drag your toes or you drag your foot when you walk, and that can increase your risk of tripping or falling. Also, when having that drop foot can cause your knee to hyperextend when you walk, and that can cause arthritis over time. I talked a little bit about the spasticity in the inner thighs. Basically, it brings your legs close together, and that makes it hard to walk with a wide base of support. And if you're not ambulatory, it makes it difficult to perform lower body dressing and maintain hygiene as well. And in the toe muscles, if you have spasticity and tightness in those muscles, you can have problematic toe curling, which can be painful, make it difficult to fit into your shoes or your braces, toe clawing. There are different postures. All right, so what are the treatment goals for spasticity management? And that's going to be different for everyone. Everybody's going to have different goals. But in general, treatment goals will be to improve positioning in a chair, in a power chair, in bed, to decrease pain. Spasticity can be painful. Improve ease of providing hygiene. So in areas that can become tight, such as in the underarms, the elbow crease, the private area, even the back of the knee, there's a lot of hamstring spasticity. Improve your function, of course, being able to walk more easily, being able to do your activities of daily living with ease, and improve cosmesis. So those are the main goals. So what can we do about it? And this is kind of the heart of the presentation here. So there are a lot of tools in our toolkit. Non-pharmacologic options include stretching, as you know, that's very important. Having a good relationship with a physical and occupational therapist who can give you a good home exercise program and demonstrate how to do, the appropriate stretches in both the arms and the legs to prevent you from getting contracted is key. No matter what other treatments you pursue, stretching is important. There's also splinting, which can provide a dynamic or a static stretch. And I'll show you what I mean by that. I have some images of splinting devices, and basically they just stretch you throughout the day, again, to prevent you from developing contractures. There's also serial casting, which is when a therapist will gradually improve your range of motion at, for example, your ankle or your elbow joint, by casting you and gradually improving that range of motion and stretching your joint and muscles. And then the options that I offer are pharmacologic. So those options include oral medications, focal injections, so botulinum toxin injections, I do a lot of those. There's also phenol blocks, which are nerve blocks. There's intrathecal baclofen pumps, that's an option. So there's a lot in the pharmacologic category. And then there are surgical procedures. I won't be talking too much about those because I'm not a surgeon, but I'll bring up some of the main ones that are done to address spasticity that has created contractures at the end of the talk. So we talked about stretching. That's one of the non-pharmacologic options, splinting. So whenever I see someone in my office, regardless of what treatment plan they're on, whether it's oral medications, whether I'm doing Botox injections or phenol blocks, it's good to give them splints. And that's for them to wear at home for, honestly, as long as they can tolerate it. I'm happy if they use it for just a few hours a day, really, just to prevent contracture and get a good stretch in the day. So these are some common splints. These are pictures from Dynasplint. So this is a wrist extension Dynasplint. It goes from 45 degrees of wrist flexion all the way to pretty much full wrist extension. That way we can provide, you can control the amount of stretch you get. And then there are different hand attachments. Some people will have a very tight fist and they can only tolerate a padded palmar bar. Some people may prefer the anti-spasticity ball hand. So, but this is a really good option. So this is the dynamic splinting option. On the right is just a resting hand splint. So this is the static splint that you can use in the wrist, which just keeps your wrist and fingers in place and prevents it from curling up and getting tight. We also have splinting for the elbows. So for those who have elbow flexion or even elbow extension spasticity, we have a similar device that can provide a stretch dynamically. You can adjust it manually to deliver the kind of stretch that you want and can tolerate. And on the right, we have the static splint, which again just prevents you from going into full elbow flexion and preventing those contractures from developing. And then in the lower limbs, we have knee splints. So for somebody who has spasticity in their hamstrings, we want to stretch those hamstrings and get a little more knee extension. There's the knee flexion Dynasplint that can gradually stretch out your leg. And then when you're done with that stretch, you can put on the resting splint, again, as tolerated, what patients can tolerate. And then lastly, in the ankle, we have a dorsiflexion Dynasplint. So a lot of people will have spasticity in their calf muscles, and that's what plantar flexes your ankle or makes it point all the way down. This will do the opposite. It dorsiflexes or pulls your foot up, which stretches that calf muscle and prevents that joint from getting stuck with the foot pointing down. You can stretch actively with the Dynasplint, and then when you're done with that stretch, you can put on, like at nighttime, for example, you can put on the safe boot to get a stretch. Again, all of this is just as tolerated. So we talked a little bit about the non-pharmacologic options. Very important to stretch, do your therapies, and splinting can be a good option for a lot of people. Now, this is my arena, pharmacologic treatment options. So, starting with oral medications, these are the big three that I prescribe for management of spasticity. These are the ones that are approved for spasticity. So there's tizanidine or Xanaflex. I like to use that one if somebody has high blood pressure because one of the side effects is that it drops your blood pressure a little bit. So it's good for that group of people. There's baclofen, that's a very common one. I just like to be careful with this one. I don't prescribe it for somebody who has had a history of seizures, and I always educate everybody if you're on a high dose of baclofen, you want to make sure you don't abruptly stop because there are withdrawal symptoms that you can develop from that, such as hallucinations, rebounds, spasticity, and seizures. So it's just one to be cautious with, but it's very effective. And then lastly, dantrolene is one that I like to use with anyone who has chronic kidney disease or end-stage renal disease and is on hemodialysis. Dantrolene is a good one because it's not metabolized by your kidney, it's metabolized by your liver. So if anybody has kidney issues, I can use dantrolene. So these are all really good medications, but they can be sedating. They all have that same side effect. They can be sedating, especially at high doses. So that's something to keep in mind. Next is chemodenervation with botulinum toxin. Some of you may already be aware of this option. It's a really good option because it's a focal treatment option. It's not a medication that you take and has systemic side effects. So botulinum toxin is injected directly into these spastic or overactive muscles. And how does it work? It basically disrupts the release of a neurotransmitter called acetylcholine at the junction between the nerve and the muscle. And by doing that, by disrupting that release of acetylcholine, it reduces muscle contraction and relaxes the muscles. So that's how Botox works. It relaxes muscles. And it only works where you put it. So it's a focal treatment option and ideally avoids systemic effects. It does take a couple of days for it to take for you to notice it, 3 to 4 days, but typically more like 7 to 10. And the peak effect will be around 3 weeks. It lasts around 3 months. There are different formulations that are available in the US, and those are Botox, Dysport, Xeomin, and Myoblock. I'm comfortable with all 4 of these. If you're interested in botulinum toxin injections to treat your spasticity, I recommend you speak to your neurologist. If you have a physical medicine rehab doctor, talk to them. Maybe your therapist knows somebody who does this. There's also a website where you can look up providers who inject Botox and Dysport and Xeomin for spasticity management. And just to give you an idea, these are the muscles that are approved for Botox injections in the arms and the legs. That's because the initial trials were done with these muscles, but most providers will inject any muscle that is spastic because further studies have been done and have shown positive results with good relaxation and improved range of motion with the use of Botox. The next tool in my toolkit is chemoneurolysis. So instead of going after the tight muscle, I go after the nerve that innervates that tight muscle. And I do this with phenol. So chemoneurolysis is basically a nerve block using phenol, which destroys that peripheral nerve, the nerve that innervates the overactive or spastic muscle. And that's how it produces relaxation. The good thing about phenol is that it works immediately after the injection, and it lasts about 6 months and longer in many cases. But I can't do it everywhere. I don't use, because of the effects of the phenol, I don't ever do it in the neck, in the chest wall, in the hands, or in the feet. The other thing is not everybody is trained to do phenol chemoneurolysis. I think there are a lot more providers who are comfortable doing Botox injections, but not as many who are doing phenol. Phenol is helpful, for example, when you have a lot of spasticity and there's just not enough Botox to adequately treat all of those muscles with the appropriate dosing without going over the recommended dose. So it's really helpful in those cases. So we talked about non-pharmacologic treatments. We talked about oral medications, Botox injections, phenol blocks, and then there's baclofen pumps. So baclofen pumps are a really good option for anyone with lower limb spasticity. And that's because of the way that it's implanted. It doesn't really help with spasticity in the arms. So when I see somebody in the office, I mention, all of these different treatment options. And if they're interested in a baclofen pump, the good thing is they don't need to commit to it right away. I always do a trial for someone who is interested, and that can be done in the outpatient setting or in the OR. You don't need to be admitted for it. It's a pretty quick procedure, actually. But basically, they will inject a 50 microgram bolus of baclofen into the intrathecal space of the spine. So it's like doing an epidural. You just go a little bit further. And then your spasticity can be assessed right before, 2 hours after the injection, and 4 hours after the injection. And that's because the peak effect of intrathecal baclofen is around 4 hours. So at around 4 hours, you will know if you like the effects of it. Your doctor or your therapist can stretch you out and see if there's improved range of motion. They can watch you walk. And if the trial is successful, the next step is to then coordinate with the neurosurgeon who does the actual implantation. And this is what the baclofen pump looks like. It basically looks like a little hockey puck, and it can contain 20 to 40 milliliters of fluid or medication in that pump. And it's connected to a catheter, and that catheter will be implanted into your spine, into that intrathecal space, so it can continuously deliver medication into your spine. And the pump goes typically in the abdomen underneath the skin, subcutaneous. After that's done, then you need to follow up, usually with a neurologist or a physical medicine and rehab doctor, to have that baclofen pump refilled every couple of months. And every 6 to 7 years, it does need to be replaced because the battery does end around that time. And what I like about the baclofen pump is that we're talking about micrograms of medication with the baclofen pump. So when you're taking oral baclofen, those are milligrams because it goes through your system, it's metabolized by your kidney, and you have all these side effects. But with this, micrograms, you're using like 1,000 times less than you would with the oral dose because it's targeted. And the way that I like to compare oral baclofen and intrathecal baclofen is by thinking about a little splotch on the wall. Taking oral baclofen, it's kind of like getting a bucket of paint and throwing it on that wall to fix that small splotch. Whereas a baclofen pump, it's like taking a spray can, getting up close to the wall and fixing that little splotch. It's very, very targeted therapy, and that's why you don't get sedated with the baclofen pumps, because you're using very little medication. It's just targeted exactly in the spine rather than being absorbed in your system like an oral medication would. So it's a good option for certain people. And then lastly, we have surgical options. So sometimes spasticity can be so severe, and if it's untreated, it can lead to contractures. So I'm just going to give you an example of one of the more common surgeries that are done. Essentially, the surgeries that are done are either tendon transfers, where a tendon is rerouted to change the way that your joint is positioned. The tendon can be cut, or the tendon can be lengthened. So in the ankle, there are a lot of people who have that equinovarus posture, which is when your ankle points down and turns in. For those people, they can get an Achilles tendon lengthening procedure, which lengthens that Achilles tendon, allows the foot to become more flat, and then a splat procedure, which is when they take the tendon of the muscle that turns your muscle inwards, and then it reroutes it to the outside of your foot so that you can bring your foot out. And this is just an example of pre and post-op from an Achilles tendon lengthening and splat procedure. It's a great procedure, and it's a great option for the right person. Other surgical procedures include tendon lengthenings, such as the hamstrings. I've seen many patients who've had hamstring tendon lengthenings, or they can lengthen the biceps tendon or any of the elbow flexors. That's an option. All right. So we talked about all the tools in the toolkit, and now I just wanted to briefly go over some common braces that I use in the lower extremity to help people walk. So there's the solid ankle, molded ankle foot orthosis. This is a really good brace that basically brings your foot up and allows you to clear it when you walk. You can adjust how rigid it is by that posterior strut that you see. The thicker it is, the more stability your ankle has. So that's a good option for somebody who has a lot of spasticity in the ankle. There's the articulating molded ankle foot orthosis. This is also a good one because it's adjustable. There are pins that can be adjusted, and if you have the ability to bend your foot up or dorsiflex, this allows you to do that. So it's a little less restrictive than the solid one. This is the least restrictive one. This is the carbon fiber with a posterior strut. So that's if you have mild spasticity that's well controlled. It just helps bring your foot up a little bit. And it's very low profile. This is a very similar one. If you have skin issues, so for example, if you have peripheral neuropathy, impaired sensation, or a lot of leg swelling or wounds, the other ankle foot orthoses might not be ideal. The metal double upright ankle foot orthosis might be a better option for you in that situation because it's less abrasive to the skin. And then lastly, I do get a lot of questions about the functional electrical stim devices. So the functional electrical stim devices, or FES devices, are in the lower limbs. They're usually they're there to compensate for voluntary motion, and they're trying to mimic the ankle dorsiflexion. They try to bring your foot up and help you clear when you walk. And there are a few that are the most common ones, or the ones that I've seen and worked with, are the walk aid system, the Bioness, and then there's another one that came out, and I'll show you in the next slide. But basically, these two devices, they help bring your foot up and clear the foot when you're walking. That drop foot during the swing phase of your gait, when you're swinging your foot, is one of the risk factors for a fall. So it is something that's important to address. These devices work by using little surface electrodes that are fixed with the cuff that you can see in the images on the right, and typically go below the knee, and they deliver electrical stimulation during that swing phase of gait. And that's what produces the ankle dorsiflexion, or pulls your foot up and helps you clear the foot. The issue with these is that they're typically not covered by insurance. The major trials that have been done have shown mixed results. So the main one looking at the Bioness is the fastest trial. So there was a foot drop stimulation versus traditional ankle foot orthosis after stroke trial. This was done in multiple centers, and they compared the Bioness with a traditional brace, and they looked at it over a period of 30 weeks, and they found that both yielded statistically significant improvements in gait speed and other functional outcomes. So basically, they were both helpful, but no difference was found between the two groups. That said, some people don't tolerate the traditional ankle foot orthoses and might want to try an FES. The other trial was the Rally trial, and that looked at, it was very similar, but it looked at the walking device. And it showed that it could improve walking ability, but the results were mixed. Further studies have been done in different population groups, so MS and different groups of patients, and have shown some promising results. So it really varies. I will say it can be a bit finicky putting these on. Um, if you do have one, you might want to bring it into the doctor's office, make sure you're putting it on correctly. So I don't use these often, but in a motivated patient who's really interested, I have no problem with using this. I'm just very transparent about the trials that have been done to show mixed results. And then there is a newer one that's kind of exciting. It's the psionic neural sleeve. So this is like bionic clothing, and it's been used. It was first studied in patients with multiple sclerosis, and this is what it looks like. It's on the right. It's basically like a piece of clothing that you put on your thigh and calf, and it uses electrodes to stimulate your muscles. So it can stimulate your hamstrings, your quadriceps, your calf, etc. And they looked at it was a pilot study, and it looked at your ability to bring the foot up and your ability to evert your foot. And the results were promising. So you can see in this graph on the bottom left, in blue, those are the people who were using the psionic neural sleeve. They were able to dorsiflex their ankle or pull that foot up a lot more than those who weren't using it. And when looking at inversion, which is when your foot turns in, those who are using the psionic neural sleeve were better able to avoid that posture because you don't want to walk on the outside of your foot. So it corrected that issue. So it's promising. It's definitely a good design. So the future is bright. There's a lot of research going on in spasticity management. I think at the top of that list is cryodenervation, which is currently done in Canada, and if a few physicians will do it in the United States. But basically, iovera has a device that uses liquid nitrogen to generate pressure changes and create an ice ball that can be used to destroy peripheral nerves that innervate the tight or spastic muscles. And what's nice is that you're doing a nerve block, but with ice. It's not an oral medication. It's not a toxic chemical. It's ice. So it's a really great option. They're doing it in Canada. There's currently an ongoing trial right now at some of the major hospitals in the U.S. looking at cryodenervation for spasticity management. We are already using this technology in the pain management world. So, for example, somebody with knee pain who isn't a good candidate for a knee replacement and they failed steroid injections or the gel injections, they can get cryodenervation of their genicular nerves. Those are the ones that provide sensation in the knee, and that can control their pain. So it's already being used and it works, but it's not being used for spasticity. There's an ongoing trial looking at cryo for that reason, which is very, very exciting. There's also hyaluronidase. There's a researcher at Johns Hopkins that has found out that there's an accumulation of hyaluronic acid in muscles that are spastic and immobile. So you need hyaluronic acid in order for those muscle fibers to glide and slide against each other. But if it accumulates, it can cause fibrosis and ultimately muscle stiffness. So her hypothesis, this is Dr. Raghavan, is that hyaluronidase, the enzyme that breaks down hyaluronic acid, can be used to address muscle stiffness. And she did a case series, actually. She looked at 20 cases of patients who had spasticity in the arm and injected them with hyaluronidase, and the results were very, very promising. So that's something else that's being researched at in New York and at Hopkins. I think those are the main centers. There's also a lot of research going into different toxins. So we use Botox or Dysport, and it works well. But it would be nice to have a toxin that lasts longer than 3 months. So there's daxibotulinum toxin A, or Daxxify. This is a newer toxin that lasts up to 6 months, which is great. But it's only approved for cosmetic reasons right now and for the treatment of cervical dystonia. There is an ongoing trial looking at the use of Daxxify for spasticity. So that's an exciting one. If you do well with toxins like Botox or Dysport, Daxxify would be a great option in the future because it just lasts longer. There's also research going into shorter duration toxins. So it would be nice to have a toxin that had an immediate onset. You go to the doctor's office and you try it out, and you know within that day whether this is a good option for you or not. So essentially, it can be used as a diagnostic tool. And the good thing is, if you don't like the effects, it only lasts 2 weeks. So that's botulinum toxin. They're doing research on that. I think that one would be great for diagnostic reasons to let people trial these toxins and not commit to a full 3-month treatment. And then I just wanted to share a patient story with you all. I think this summarizes everything that we've talked about, and it's a great story. I like to call this one the combo platter, please, because there are so many tools in the toolkit, and this patient ended up requiring multiple different treatment options to achieve his goals optimally. So this is a 55-year-old male who came to our clinic. He had hereditary spastic paraparesis, and he presented with spasticity in his legs. He stated that it was difficult to spread his legs apart when he was walking. He tended to scissor a little bit. He dragged his foot, and he had difficulty fully extending his legs. So he walked with a crouched gait, and he took really short strides. His walking was very effortful. On my exam, there was spasticity in multiple muscle groups in the legs. So in the bilateral inner thigh muscles, those are your adductor muscles, they were very tight. His hamstrings, as well as his calf muscles. When I spoke with him, he said his goals were to improve his gait, to go on longer walks in the neighborhood, and to travel. He wanted to go to Italy and do all these great tours, and he just wanted to be more active. And then he also wanted to improve his sleep by addressing his nocturnal spasms. He had these painful spasms at night and wanted to address that. So we came up with a thoughtful treatment plan to ensure he could achieve these goals. He had a lot of spasticity, so we're not going to be able to treat that with just oral medications or just toxin. It's going to require a multi-pronged approach. So first thing is we started him on a very, very low dose of tizanidine, just 2 milligrams at bedtime, and that seemed to be enough to control those spasms at night. We then did phenol blocks to the bilateral obturator nerves. So the obturator nerve, that's what innervates your inner thigh muscles. So he had tightness there, so we did phenol to those nerves, and that allowed him to spread his legs apart and walk with a wider base of support. We then did chemodenervation, or the Botox Dysport injections into the calf muscles to address that drop foot, that equinus posture, and help him bend the ankle better. And then lastly, we did cryo to the nerves innervating the hamstrings to allow him to better extend his leg. And then once we did all of that, we had him come into our gait clinic, and we had him fitted for ankle foot orthoses that were most appropriate for him. And he did great. He's thriving. So this was a really wonderful case that I wanted to share with you. And that's everything that I wanted to share. So thank you so much for your attention on a Saturday. I wanted to make sure there's ample time for you to ask any questions. So once again, thank you so much.
Thank you so very much, Dr. Martinez. We really greatly appreciate that. That is a lot of information, a lot of big words, but very good information. So now you'd like to take some questions to me. Not sure what happened.
I know. Can you hear me?
Yes, sir. Go ahead, please.
Okay, Libby sent me this link, so that's why it has her name on it.
Okay, good.
So,
No problem.
Dr. Martinez, awesome presentation. One of the best I've heard around spasticity, so I want to commend you on that. I know that you can't give specific advice as patients, but this is a two-part question for me. Can you use like tizanidine, baclofen, any of those in combination? And then my second question is, at what point do you move from an oral treatment of baclofen or tizanidine till you recommend, or when a patient maybe should start to consider a baclofen pump?
Yeah, no, those are great questions. So yes,
Thank
you
you.
can combine the oral medications, but typically, for example, if I start somebody on baclofen, I'll do 5 milligrams twice a day or 3 times a day, and then I go up before I start them on a second one. Because why start a second one if you're not maxed out on one? And then if I'm maxed out on that, I can try a second one, but at that point, I'm really thinking we might need to try toxin injections. We might need to try a baclofen trial. Um, there is a limit to how effective, and everybody reacts differently to the oral medications. So it really depends. If there's a lot of spasticity in the legs and there are a lot of muscle groups, I will typically recommend a baclofen pump trial. So if you have spasticity in your quads, in the back of your thigh, and your hamstrings and your calves, it's going to be hard to target all of that with just Botox and Dysport. So there's an upper limit to how much we can use. Don't want to get too into the details, but for Botox, for example, it's 400 to 600 units that we can use. It varies based on insurance coverage. So that won't be enough to address all of the spasticity in the legs. But if you just have, for example, a tight calf muscle and your foot is pointing down, it might be enough. But if you have a lot of spasticity, I would do like a baclofen pump trial. But if somebody doesn't want to do that, then I just say, let's try the toxin injections. It's not, it only, if they don't like it, it only lasts 3 months, and then we can do a trial. So there's a lot that you can try before committing to a pump. Hopefully that helps or answers most of your question.
It does. Thank you.
Absolutely.
Thank you, Leonard. Go ahead, Mr. Kenneth. I've got you now ready where you can ask a question. Linda, you're up next.
I have PL shape had a baclofen pump for 5 years. I have a wonderful rehab doc at Spalding in Boston. My challenge is I really have difficulty assessing if the dosage is too high or too low. I almost wish I could just shut it down and start all over. And the cold weather is like kryptonite.
Yes, the cold weather is like kryptonite.
Mhm.
The nice thing about your pump is that you can change. There are so many settings that can be changed. Like for example, if you have more spasticity during the winter time, your doctor at Spalding can easily go down on your dose. There's also different things that you can do. They can change the programming settings so that you get a little more medication at night or a little more medication during the daytime. You can do bolus dosing. I mean, the programming for a pump is quite fancy, so they can really tweak things quite a lot. So if you notice seasonal changes, you might just need a little more during some of those seasons, and your doctor can have you come in and adjust. But yeah, sometimes it's hard to get the right dose with the baclofen pump. Sometimes it's a little too much, sometimes it's too little. But the beauty about it is that you can adjust it whenever you want.
Okay, very good. Miss Linda, go ahead with your question or comment.
Well, thank you, Dr. Martinez. That was a wonderful presentation. I have a strange question. Well, not strange. I I do a lot of stretching and weightlifting, and I take high doses of baclofen orally, and it seems to be good for the spasms. I control them, but I have a really hard time controlling the temperature of my feet, particularly, but my entire legs. Could regulating the temperature of your legs be related to um, spasticity, or I'm a wheelchair user? Is it edema? Is it because I'm sitting a lot? What's
Mhm.
going on? I don't know.
Yeah, no, so that can be due to multiple issues. So the temperature in your legs, that's going to be regulated by your vascular flow. So making sure you don't have issues with the arteries or the veins. It could also be due to peripheral nerve damage that can cause impaired sensation or temperature issues. Um, The spasticity shouldn't really affect the temperature too much in your legs. I haven't seen that. Although it, sometimes spasticity can help with all those muscle spasms. It pump the blood up, help with blood circulation in the lower legs. So maybe in some indirect way it can. But I think the key thing would be to get checked out. Like make sure you don't have edema,
Okay.
because that can be due to kidney or heart issues, or make sure you don't have any issues with your peripheral arteries or veins. But it may just be due to like mild peripheral nerve damage. Hard to say. To assess that, you would need like an EMG nerve conduction study.
Okay.
Yeah, it depends on how problematic it is for you.
Whatever it is, sounds like fun. Okay, thank you.
Thank you very much, Linda. Okay, we have got, let's see who over here is lined up. I've got David. Go ahead, David Albrice, and then Barbara, you're up next.
Thank you. Dr. Martinez, thank you for a fantastic presentation. Really enjoyed that. I have spasticity, I think, in my posterior chain, my hamstrings and my calves. And I'm fortunate that I can still walk and with a cane periodically. So I consider myself to be very fortunate. I'm going to physiotherapy. And my question is about the velocity dependence of spasticity. I know that the faster the movements that I'm doing in the physiotherapy classes, the more it impacts my spasticity. So my question is this: are we better off pushing into that velocity and trying to make fast movements, or are we better off not doing that?
So I would say better not doing that, because like you said, spasticity is velocity dependent. So when I'm checking somebody for spasticity, I always warn them ahead of time. Look, I'm going to be ranging your arm really quickly, because if I do it slowly, the spasticity won't be kicked off. It's velocity dependent. So it's with any quick muscle tension change or quick range of motion. So I prefer, if we're doing stretching, do it nice and slow. When you're walking, be mindful of your movements. You definitely don't want to set it off. It won't be helpful. I don't know if that answers your question.
Yeah, so it's more, so we should focus more on stretching than trying to do any fast movements and develop anything like cardiovascular, if you will, in that way. Okay.
Yeah,
Yeah.
exactly.
All right. Thank you.
Thank you very much for that. That was great. Okay, Miss Barbara, you're up, and Beatty, you're next.
Hi. So I actually live in Central Jersey, so I may make an appointment to meet with you.
Wonderful.
But my question is with the Botox. I have a lot of friends who do Botox for vanity reasons. And the reason I don't do it is because you're pretty much throwing poison into your body. So have there been any studies about the long-term effects of, every 3 months putting poison into your muscles, especially if you have to do that, for the rest of your life?
Yeah, no, that's a really valid question. I mean, toxin injections, I mean, it is a botulinum toxin, but what I like about it is that it's focal. It's only going to act where you put it. There are risks of local or distal spread, but when it's done with guidance, either EMG or ultrasound, it shouldn't be going anywhere else in the body. And ultimately, you just have to weigh out the risks and benefits. I mean, every medication, whether it's an oral medication or whether it's a botulinum toxin injection, is going to have side effects. So it really is weighing out the risks and benefits. But what I do like about it is that it's focal, and it also only lasts 3 months. Over time, what you can see is mild atrophy of a muscle. Like if somebody's been doing it for 30 years or plus, does that I mean, is that problematic? Not more than the spasticity in some cases. So I have some patients who have said, well, my muscle's a lot smaller now. And I'm like, well, that's definitely true, and that's probably the Botox over years, but it does help with the range of motion, and it does help them move more, get more exercise. It prevents the contractures that can be so problematic. So it's all about risk benefit. But I'm very transparent about that because it isn't something that I take lightly. And there can be side effects, but if done well and done in the correct cases with the right goal in mind, it's a good medication to try. But if you don't like toxin injections, there are different things that you can try. Oral medications, nerve blocks, cryo would be really great once we get that approved because it's just ice, which is great. Um, yeah, or splinting, serial casting. There's a lot that can be done, and then also baclofen pumps. It is an implantable device, but what's nice is that it's little microgram doses. So there's a lot of options, and you just have to pick the one that you're most comfortable with. But definitely, I don't take any of those options lightly, whether it's just an oral medication or toxin or a baclofen pump or a nerve block. Yeah,
Thank you, doctor. Okay,
absolutely.
we've got Beatty, and then I've got Steve. You're up after Beatty. Go ahead. I don't know why it's showing Linda.
Hi. Can you hear me?
Yes.
Okay. Well, again, thank you, Dr. Martinez. Wonderful presentation. Okay, so my only issue now is because I've got my spasms and everything under control. So I have foot drop and I use AFOs occasionally because they're not hinged and I can still drive. But my right leg, right knee turn in. And so now what's happening is my knee is giving way. So if it wasn't for the fact that I use a walker, I'd be on the ground all the time. So I have had x-rays done, and of course they're saying it's osteoarthritis, but is there something else that I can do to help stabilize the knee?
Stabilize. Yeah, some people, if it's due to arthritis, there are knee braces that can help and reduce the pain. Do you have painful arthritis, or is it just that your knee's
No,
buckling?
no, it just, so when I walk, my right leg scissors in, so I'm always touching my knees.
Okay.
And no, it doesn't hurt or anything. It's just that I can stand and not even exert a lot.
Yeah.
And all of a sudden it just gives way.
So it sounds, and I would need an exam, but it sounds like you could still have some spasticity in those inner thigh muscles if you're scissoring a little bit, or which is very common, you can have weakness in your hip abductors. So those are your outer
Yes.
thigh muscles
Yeah.
that allow you to bring your hip out. So those
Right.
can be weak, and that might be why you're collapsing your knees. So there's either weakness or tightness somewhere, but I don't think it's arthritis, because if it were that bad, you would have some pain by now. So it might be something
Okay.
biomechanical like that.
So when it comes to, because that's where I've always had the majority of my stiffness is our abductors and up around the hips.
Yeah.
So would you consider Botox in
I
that
would,
area?
yeah. So what I would do is I would strengthen my hip abductors, which are the ones that bring your hip out, and
Mhm.
then if there's stiffness or spasticity in the inner thigh muscles, I would consider toxin injections there. But you want to make sure you get a really good exam to make sure that there is spasticity there. Also, in my office, before I commit to things, I do diagnostic blocks with bupivacaine, which is like the phenol, but with bupivacaine. So it only lasts a few hours. That way I know, is this
Yeah.
an issue? And we know right away, and it's out of your system in just a few hours. So it's a good tool but not
I've-
everybody does that.
Yeah, and I've had no ill effects of Botox in my abductors and the shin area and all that. So
Yeah.
it's just that they haven't gone higher, and that's where I'm finding now
Oh,
more of an issue.
that might be, yeah, that might be the issue then.
Yeah, because then what happens is like on a day like today where I was out and about doing some errands, because basically you're sloughing your legs around and they're heavy. That's what fatigues you, right?
Yeah, exactly. And that's the thing with spasticity. It's not just that you have impaired range of motion and difficult to walk, but over time, any changes to your biomechanics when you're walking increases the amount of energy you expend walking, and it tires you out. It
Right.
does, especially if you're active. So that's why even any slight alteration, like just a little bit of spasticity in the calf, that can tire you out more than somebody who doesn't have spasticity in the calf. And that's another reason why it's important to treat, even mild spasticity, because you want to optimize your walking so you're not expending so much energy on it.
Okay, thank you.
That is so
Absolutely.
wonderful. And you guys, you got to remember that, today is just a day and tomorrow's going to be a little different. So you got to remember to be nice to yourself. If you can't get the work done, then just put it aside. And then a couple of hours later, you might feel better, or the next day or two later, you might feel better. Just don't beat up on yourself so much, right? And take into consideration that we're all getting a little older. And that plays a big part in the way that you feel today versus the way that you might feel tomorrow, right? So, okay, Steve, you've also got some comments or questions over in the chat box. So go ahead and unmute yourself or show your camera if you would like to. And then Rhonda, you're up next. Thank you, baby.
Hello, can you hear me?
Yes, sir. Go right
Yeah,
ahead.
this is Steve Tamari. Our son, Chad, has SPG11. Anyway, he has been, and this is something we learned at the last year's conference, and I hope you can come to one of those conferences. Actually, it would be great for a lot of people to hear you. His neurologist recommended a generic Amphira. And something we heard at the conference last year was using medications that are indicated for other, illnesses. I think this one is indicated for MS. But I just wonder what your thoughts are about, that medication in particular, or the use of medications that are indicated for MS or for other CP or other illness,
Yeah.
because I don't think there's anything that's specifically prescribed for HSP.
Right. Yeah. So for example, I've personally used carbidopa levodopa on patients who have had a stroke in the same areas that are affected in patients who have Parkinson's. So that's an example of using a medication that's for somebody with Parkinson's in somebody who had a stroke, but presented like somebody who had Parkinson's. Dalfampridine I've used mainly in MS. I only used it once in somebody who didn't have MS, and it's used to improve your walking ability. The important thing is just to, bring it up to your neurologist and tell them that you want to try that medication. I think that's valid. But I just have limited experience with that one. It's mainly neurology that will prescribe that, but I have done something like that. And carbidopa levodopa is just the one that I used in a different population group. So it's certainly something that can be done and something you can absolutely bring up during the next visit. It's a good question.
Thank you.
So much, Steve. I appreciate that. Okay, Rhonda, go right ahead. It's your turn. Unmute. And there you go. Unmute. You got to unmute. There you go.
And share.
You don't have to share. No, just go ahead and ask your question.
Okay, but I gotta shut this. Okay. Hi.
Hi.
I don't even know how to explain all this, but I'm extremely frustrated. I have this in my lower extremities, and my nights when I go to bed are torture. Especially in my feet, it's like terrible neuropathy. My legs and my feet can be like on fire, and there's so much discomfort. It's like somebody would take a rubber band and wrap it around my legs tight. And I'm on 7 gabapentins a day. And I've been on baclofen. I just went to a new neurologist, and she's trying to slowly get me off of baclofen, mainly because I am in a stupor. I am so exhausted all the time, and it's disturbing. I go for physical therapy, but my gait is bad now, and now I have to use a cane. frustrating because I always danced and I missed that, but could be worse. But the medications, I'm interested in that baclofen, the pump, because maybe that I wouldn't get tired. And at night, sometimes I'm in such terrible discomfort. I try all kinds of things at night so that I could sleep. And when
Yeah.
it's really bad, I take Percocet. And that probably is one of the best things for me, but you can't take that all the time. And it leaves me in a fog. I'm just always exhausted. And I don't know if there's anything that I can do about this. I don't know if you would know at this point,
Yeah,
but
so it looks like it could be a combination of things. It might just mainly be neuropathic pain. It could be spasticity. It could be both. But
yeah,
something that you can ask your pain management or your neurologist about is a trial. Um, so I talked about baclofen pumps, but these pumps
right.
are also used for pain management, and there are pain management physicians who do both. Like you can have more than just baclofen in the pump. There's hydromorphone that can be in the pump, and again, we're talking like little small doses, so you don't have that dependency issue, the side effects of
Yeah.
oral medication. So it would be worth asking about the possibility of doing a trial, either with baclofen or with hydromorphone or morphine.
Yeah, I heard about morphine. I've actually heard good things about using morphine pumps. But, it's like at this point, I have medical marijuana license, so I will use that at night. And then
Yeah.
things seem to work for a couple of nights and then they don't. And then I'll take a gummy with THC in it. I'm sure that contributes to me being tired. But I just, it's really, really tough. It's tough for me to function. And I'm
I'm
a
sorry.
realtor. So I don't know, if there was anything else that you could think of.
Yeah, I mean, it looks like you've
But I,
tried all of the oral medications. If you're curious about a trial, that's the nice thing about a trial, that it's just a trial. And if you don't like it, it's just a
yeah,
trial. You don't have to get the pump. But
I'm going to definitely discuss
yeah,
that
yeah,
with
definitely have
pain
that
management.
discussion.
What do you think about the 7 gabapentins? Do you have any thoughts on
Gabapentin is,
that?
yeah,
That I,
gabapentin is a good one for neuropathic pain. There's also other medications that work as well, like amitriptyline or nortriptyline. They all
yeah,
have side effects. So
yeah.
but sometimes people do better with Lyrica rather than gabapentin, and everybody
Yeah,
a
I
little bit.
had some kind of bad reaction to
Yeah.
lyric. I don't remember what it was. But
Mhm.
anyway, I just wanted to mention because, as I said, my nights are just, I dread going to bed.
Oh, I'm sorry.
So
Bring it up
I
to
just take things that knock me out. They're
Mhm.
not really helping what I have, but I'm trying to find things that will just knock me out at night.
Then
So
considering a
it's bad
trial.
because during the day I'm tired but then at night I
Yeah.
need things to help me sleep. So just frustrating, but hopefully I'll get there.
Well, Rhonda, thank you so very much for just being so out there and
Thank
honest
you.
about
I
what
thank
you're dealing
everybody
with.
here. Mhm.
Yeah, absolutely. Thank you very much for that. You might even contact like the local health food store and talk to those folks about some natural, healthy remedies that they
Yeah.
may be able to offer, like some type of teas that can help
Okay.
you perhaps maybe relax as well.
Okay, I'll do
Yeah.
that. Thank you very much.
Good to see you. Thank you for joining us this afternoon.
Thank
But
you.
we have Ted Jaderstrom over in the chat box that can't seem to get his hand raised ability. So we're going to call on him and see if we can get him on screen here. Ted, do you hear us? Can you go ahead with your question? And then
Yeah.
Susie, you're next. So y'all hang on. There's a couple of people in the wings and we still have questions over in the chat box, but hang on just a little bit. Ted, are you with us?
Yeah, I can hear you. Can you hear me?
Yes, go right ahead.
Okay, so I live in
So
Hawaii
this
and
goes on for another half
had,
I
hour?
don't know.
Oh, go ahead.
Can I have somebody go on?
yeah, I'm sorry, there was somebody kind of got in. I'm in Hawaii. I've had, I guess, symptoms since I've been in my 20s. I never noticed them. People ask me why do you walk that way. I don't know
These
what
are
they're
the
talking
tortured
about.
people like you, dear.
Uh-oh, wait a minute here.
Uh,
Oh, Oh, Tom,
Hello.
you're gonna have to mute yourself, please, sir. Please go
Okay,
ahead.
and then sorry. So finally, my family doctor said, you know what, you got to go to someplace else because nobody in Hawaii knew what was going on. Yeah, they misdiagnosed all kinds of different things. So I went to the Mayo Clinic in Rochester, Minnesota, back in 1999, and they told me what it was. But I look at that example you gave of the 55-year-old guy, and it's almost exactly what kind of symptoms I have. Yeah, with the gait and what you call the scissors, and
Mhm.
the crouch walk and all that. And I get spasms, but there's no really a rhyme or reason as to when I get them. Sometimes I don't get them all for the whole day. One time when I went to Japan, I went to the hot springs, and it went away for 2 weeks. And yeah, it used to only come at night. Now it can come at any time, and they last for about anywhere from 10 to 20 minutes long. I found if I whack my thigh, the spasm will go away, but it won't stop. Another one will come. I whack my leg, it goes away immediately. Yeah. And I
Mhm.
find when I stand, it doesn't. The spasms go away. If I'm sitting, the spasms will come. But if I stand and walk around, they go away. Now my question is, here I am in Hawaii, and it's kind of expensive for me to travel to all those places. And what do I do for these treatments? I don't like to take oral medications because I've had bad luck with such things. Yeah, so I try to stay away from that as much as possible. So, Dr. Martinez? What are your suggestions?
I would suggest looking up a physical medicine and rehab doctor in your area. That would be the best thing. Certainly neurology is
Medicine and rehab.
we work closely together, but physical medicine and rehab would be a good option for you because they do a lot of
Write that down.
interventional pain management, spasticity management, and if they're not comfortable with it, they'll definitely know somebody in the area who is. So getting in to see, I think PMNR, physical medicine rehab, would be helpful for you for sure.
Can you write it down? I'm not
I
sure.
don't have anything to write on, but I'll remember.
Wait, Tom, can you mute your microphone? Go ahead, Doctor.
Okay. So, I mean, I'll do whatever it takes, but yeah, just the only thing considered expense and the distance I am. I don't know if we have anybody like that. We probably do, but I'll talk to my family doctor. Maybe he knows.
Mm-hmm. Yeah, he'll definitely know a physical medicine rehab doctor in the area. They're really well connected. Like the primary care doctors are well connected, and they can give you a referral, and that's gonna be a good starting point for you.
Yeah, because I had a knee injury back about 14 years ago, and that kind of made things a little bit worse because it turned into arthritis. Yeah, and I use a walker not because of that, but because of I had a spinal stenosis surgery, and it was mega pain keeping me up all night, and then I couldn't stand more than 30 seconds. So I had to use a walker, and I got epidural a couple of weeks ago, which made most of the pain go away. But the thing is, like, I got dependent on his walker, and I'm trying to get undependent on it because I'm still work. I'm a teacher at a school, elementary school teacher, yeah, and it kind of gets in the way.
Definitely physical medicine rehab. I think that's gonna be the best way to go for you for sure.
Okay.
Thank you very much, Ted. I appreciate your reaching out, being with us this afternoon. Thank you so very much. Okay, we have Susie. You're up. Go ahead, please. And then I've got Diana over here in the chat box that wants to ask something in Spanish. So hang on, Diana. We'll get to you after Susie. Go right ahead, Susie.
Okay, so Dr. Martinez, this is regarding my son. He's 22 years old right now. He does have a baclofen pump. We've tried so many medications between the pump and all the medications. I'm not really seeing any results. He's in a wheelchair now. He does have the scissoring. He does have the foot drop. We've tried AFOs. Other than that, he also has urinary incontinence. So, I don't know if you would recommend anything for that. And then I also wanted to ask you about the cryodenervation.
Yeah, the cryodenervation, yes.
So, I think you had mentioned that it was still in the process of being approved, but then in your patient story, you said that the patient got to use it. So I'm kind of curious, like, how can we get him to try it out, or do we still have to wait?
Yeah, so I know some physicians who are already using it at Penn and in some other locations. I mainly know about people in the Northeast. It's currently off-label, but it can be used for pain. So they can use it for pain associated to spasticity, and that's how people are currently using it. Um, I I mean, I don't, there aren't too many people who are doing it yet because we're still doing the trials. One question I would bring up though is, is that pump, was it ever, did it ever help? Because one question that I have is the medication really going through? Is there pump malfunction? That's something to consider.
Yeah, the problem is I can't always prevent him from falling. So he has a lot of falls. And so I worry that that's the reason that the pump will stop working. He's actually had it replaced several times, even before, the battery, died. And so, that could be the reason. If sometimes it feels like sometimes it works and sometimes it doesn't work. So I really have a hard time telling, if it's the pump or if it's something else.
Yeah, so it could be that the pump is not working, and that might be the issue, especially if the trial went well initially and it worked. The other thing is to remember that baclofen as well as toxin injections, all of that, they work by relaxing muscles, so it won't address the weakness part. So if there's new weakness that's developing, that's addressed by therapy. It won't help with weakness. It just helps by relaxing muscles. So there could be an issue that it's weakness and he needs therapy. It could be that the baclofen pump is not well connected and there's some type of pump malfunction. I think cryo is a great option. You can bring that up to your neurologist, or if you have a rehab doctor, and they might know somebody locally who's doing it. That's my best advice.
Yeah, unfortunately, he doesn't have any pain. So, if that's what you're saying is the easiest way to get it prescribed, we might not be able to do it.
Yeah, but I would bring it up to your physician, bring up cryo, and they might be able to talk to you further about them. They might know somebody who is doing it. So definitely bring that up. This is new information that you now know, and I hope it empowers you to ask about it when you go see your doctor.
Okay.
Yeah.
And then do you have any recommendations regarding the urinary incontinence, which I understand is related to that from what his doctors have told me.
So that can be due to a lot of things. I would definitely defer to the physician who's taking care of him regarding any kind of urinary incontinence. Something that I always do if there's urinary incontinence is to make sure there's no UTI, because that can cause that. Also, certain medications can cause urinary incontinence. So I would bring that up that it's one of your main concerns, and discuss whether it's medications, whether it's the underlying disease, or possibly a UTI.
Okay.
Yeah.
All right.
Thank you, Susie, very much for your questions. I really appreciate that. Matter of fact, we are going to be looking at trying to find us someone that will be talking about urinary issues and incontinence. So hang on. We're trying to get one of those kind of speakers, and we'll be e-blasting that out. So thank you very much for participating with us today. Now, Diana is going to ask her question. If you don't mind, Dr. Martinez, is after she asks it, if you would just translate that, what that means in English for everyone, and then we'll wait patiently for you to answer her in Spanish, but come back and answer that for us also in English. And then you guys, we've only got 3 more hands raised for questions, so we're only going to take 3 more after Diana. There's a couple of folks that are in the chat box, so we're going to be coming back another time. Perhaps Dr. Martinez will join us for round 2, and then we'll have some more time for questions at a later date. So let's go ahead and get these 3 that are lined up after Diana. Go ahead, Miss Diana, unmute. I'll let you take over, Dr. Martinez.
Okay.
Tell her she can unmute.
Oh. Sí, si tienes una pregunta, lo puedes hacer ahora. Diana, no te puedo oír, tienes que cliquear el botón.
Buenas tardes, le hablo desde Ibagué, Tolima. Yo tengo una niña de 6 años, 7 meses, se llama Violeta. y pues en el momento ella caminó hasta los 4 años y medio. Era una niña normal, saltaba, bailaba, bueno, hacía todo dentro de lo normal. Después ella empezó a caerse, a tener problemas de caída, a tener problemas de que no tenía pues ya fuercitas en las piernas, de pararse, bueno, todo. Y ahorita empezó a andar en puntas y como a cruzar como la caminada, ¿sí? El caminado. Y pues a ella le aplicaron el año pasado en la Roosevelt en Bogotá la toxina bulímica. Ahorita le mandaron el gamaventin, pero a mí me ha dado mucho miedo dárselo porque pues yo no veo que la niña tenga problemas de cerebro, nada más, solamente que no tiene fuerza en las piernas, ella se cae. Y pues por lo que está, ella tiene caminador y pues nosotros la vivimos alzando porque pues ella no puede caminar largos y ahorita pues menos está caminando, ya hace como un mes para acá empezó que le duele, que se cansa, entonces ya no camina. Pero ella va al colegio, ella estudia, está en primero A, es muy pilosa y tiene muchas ganas de volver a caminar. Eh, Nosotros estuvimos en Bogotá ahorita esta semana y el doctor nos dijo que posiblemente pues le mandó unos exámenes para ver si de pronto la operaban, de pronto para poner que el pie volviera porque ella está caminando así en punta, o sea, en punta. Y nosotros le estamos dando unos productos naturales de donde una doctora acá en Ibagué y resulta que pues le han servido mucho. Violeta empezó a hablar enredado, o sea, no se le entendía mucho cuando hablaba clarito. Nosotros dimos, pero ¿qué pasó? No sé, pero pues ella con su genética dijo que ella tenía una paraplegia espástica 76 progresiva y hemos visto que sí es progresiva. Entonces, pues nosotros yo lo que quiero es la cura para mi hija. Nosotros la adoptamos a los 2 años y pues estaba bien y nosotros sentimos que después de la vacuna, que se le aplicó la vacuna del COVID, como que le activó ese gen y empezó así, ¿sí? Nosotros estamos haciendo todo, todo por ella, donde tengamos que ir con de la mano de Dios y por eso ingresé a esta fundación, pues mirar a ver qué nosotros podemos hacer por ella.
Lo siento, lo siento. Voy a traducir, okay? So just to briefly translate, Diana just mentioned she has a 6-year-old daughter, has had difficulty walking, has that scissoring gait, has that equinus or the drop foot, and she's not walking well. She went to see a physician in Colombia, was diagnosed with spastic paraplegia, and now she's asking about treatment options. So just briefly to translate the question. Diana, lo que yo recomiendo es que tienes que hablar con un fisiatra o neurólogo en tu área, pero específicamente un fisiatra, porque el fisiatra te puede ayudar y te puede explicar los diferentes tratamientos que pueden tratar. No necesariamente tiene que ser cirugía, puedes hacer esas inyecciones del Botox si notas que hay espasticidad o es difícil enderezar la pierna. Si hay espasticidad, entonces las inyecciones trabajan, hay medicamentos que puedes tratar y también el baclofen pump puede ser algo, pero es bien importante encontrar un fisiatra. Un fisiatra es que se especializa en eso, te puede ayudar.
Sí, nosotros estamos ahorita con neurofisiatra, también la volvieron a mandar y pues lo cambiamos el fisiatra. Y pues el neuro le mandó el gamaventin, sino que yo tenía miedo porque pues ahí dice que para problemas de pronto, personas que tienen ¿cómo se llama? Ataques epilépticos, y dice que problemas de cerebro, y pues yo no, ella no tiene eso nada, entonces a mí me dio miedo dárselo, por lo tan chiquitica.
Entiendo, yo sé, es difícil. Pero lo mejor que puedes hacer es ver un fisiatra y yo no veo ningún problema con esas inyecciones, pero debes de hablar con el fisiatra para que él pueda hacer un examen y determinar qué es el tratamiento adecuado. Okay.
Oh, bueno, muchas gracias, muy amable.
Well,
Thank you
All right.
very much, Diana,
I
for
was
being here.
just to briefly translate, I just explained that very important, without doing an exam or anything like that, very important to see a physical medicine and rehab doctor, especially if they specialize in neuro rehab and are comfortable treating spasticity, because there are multiple treatment options. If there's tightness in any of the muscles, then certainly Botox injections can be tried, oral medications, maybe a baclofen pump trial. It's very complicated, and it's best to, you need a really good exam to figure out what the best treatment options are. So just to summarize my response.
Thank you very much, Dr. Martinez. I really appreciate that. We have 3 more people that are in the question, got their hands raised. Tyler, go ahead. You're up now, please.
Hey, thanks everyone. Thanks, Dr. Martinez. Really great presentation. I was diagnosed with CP when I was about 5 to 7-ish, more like 5. So the whole time I'm now 42, been told I was CP. Had my second daughter, and she actually has HSP. So by default, I have HSP, and I'm need to do some more genetic testing on it. But a few questions. I've been on baclofen for about 12 years now, and I'm up to about 40 milligrams orally a night. And then I take some about 10 milligrams in the morning just to kind of cruise through the day. It's mainly at night that I have spasticity. And it's kind of like just it flares up every once in a while. However, I know that HSP is progressive, CP is not progressive, and now I'm working out quite a bit more, doing some more stuff. I'm noticing that I need to get some orthotics. I saw that you had a few options out there. My daughter is in AFOs right now, and she's 3. And so, but I was looking at the carbon fiber versus the other ones that you have, and I was wondering if you have any recommendations or if that's specifically to be left to the provider with respect to determining which one to get. Second part of that question is getting some pain from like arthritis, it appears to be, and I'm wondering if you think that the drip of or the pump may be a better way of doing it so that I'm not like overloading with baclofen and kind of pain management, like too many pills and whatnot.
Yeah, so for first part of the question, regarding the different orthoses, definitely it depends on the exam. So she needs a really good exam, but in general, if there's a lot of spasticity, if it's very hard to bend the ankle, I prefer a solid ankle foot orthosis versus a hinged or a carbon fiber one. The hinged is usually like an in-between option, and it's nice because it's very customizable. The carbon fiber, it's nice, but it can't be adjusted after it's made, so it's not as adjustable as a hinged or a solid ankle foot orthosis. And it's mainly used for mild spasticity. That's why it's so low profile. So if you have a lot of spasticity, it might not be as helpful. So it depends. And then second part of the question, I would bring up doing a trial and seeing how that affects you, because that's really the only way to find out. But if you have spasticity in the lower limbs, a baclofen pump is a reasonable option, and doing a trial is a way to find out whether you like how you feel when you're on that.
Okay.
Yeah.
Thanks. Yeah, I had 2 gastrocnemius releases. I had a tendon transfer. I've done all that kind of stuff, but I think yes, I'll leave it offline, let others finish up here. So appreciate your time and thanks for response.
Thank you very much too, Tyler. I appreciate your being here. Next we have, is it Sharita? Please go ahead and ask your question. Did I pronounce your name correctly? Unmute yourself.
I think it's Schluti. Schluti. Yeah.
Hi, sorry, can you hear me?
Yes, go ahead. Thank you.
Thank you, doctor. That was a really good presentation. I'm actually in England and it's bedtime here, so I'm not putting the video on, but just a couple of questions if you don't mind. One, is that bionic sleeve available in England? And is there any way I can get hold of it, even if privately, even if, could I order it from America, do you know? And my question number 2 is that in the patient example that you gave at the end, where you used sort of a cocktail of treatments to get him better, what was his functional status before and after, and why did you use chemodenervation for the gastroc and the soleus, but the chemical denervation, but the ice treatment for the hamstrings? How do you choose which one to use for which muscle group? Thank you.
Yeah, absolutely. So again, just a disclaimer for any advice that I give during this talk. I always recommend you consult your physician. So, but I'm happy
Yeah.
to share information, but definitely always consult your
Yeah.
physician. It can be considered medical advice. So just my disclaimer. But so for the cyanic neural sleeve, I would you can look it up online, and they actually ask like 5 questions to see if you qualify for it. But before you even do that, I would recommend bringing it up to your physician, and they might be able to order it for you. It's hard to get it approved by insurance. I'm not too sure how that would work in England. Sorry. But bring it up to your physician, and then if they think you're a good candidate for it, you can purchase it privately. So that's an option. And then regarding I think I missed part of the question towards the end, but the case that I shared, so the patient was walking before I met him, but it was very, very effortful, and he's a very active man. So his goal was to do a lot more walking and do it more effortlessly, and also decrease his falls risk. So
Yeah.
and because there was so much spasticity, he also didn't want to pump. So in order to adequately address all of that spasticity, I needed to use multiple tools. So I couldn't just use Dysport or Botox because I would end up diluting it. You need to use the right amount and the right muscle. So there just wasn't enough toxin to address all of that safely. So that's why I used a combination approach. I did a little bit of phenol, I did a little bit of toxin, and then cryo. So sometimes it's necessary to try different tools to adequately address spasticity, because there is an upper limit of how much toxin we can
Yeah, no, I get that. But was there a reason why you used chemodenervation for certain muscle groups and cryo for the other? Or is it just, how do you differentiate which treatment to use for which one? Because the neuro rehab consultants I have seen here, and I have seen quite a few to be honest, they don't have any idea about these treatments. Of course, they do Botox and phenol, but they don't have any idea about cryodenervation. I don't think we are here up to that at the moment, though I will explore further. But how did you decide on the muscle groups?
Yeah, so honestly, it's part it's somewhat of an art when you're looking at someone. You just decide there's an upper limit of how much toxin I can use, so I need to figure out the dosing, and where that's going to depend on the muscles. It's a little bit complicated to fully explain, but essentially a lot of it depends on the dose, and also the phenol. I can't put it everywhere. There are only certain locations where I feel comfortable doing it. But there are, like, that treatment plan, I could have changed it up a little bit, and I could have had similar results. The key is that I needed to use multiple tools. That's the key from that story. Like, I could have done toxin elsewhere and phenol elsewhere. I could have switched up a few things and still had good results.
Yeah.
So, but the key is that you might need more than one thing. And cryo, it's still off label. So, a lot of people aren't going to be doing it.
Okay, thank you so much.
Thank you very much too, Sharia. We appreciate your being here today. And now you're going to be able to capture all this information on our YouTube channel. And then all you got to do is take your smartphone in there with your doctor and say, here, look at these things. We need for there to be consideration beyond just some of the people that are using it for cosmetic purposes. So, we need to work on that, and we need everybody in the whole world to realize that there are some treatments that need to be made available for us. We've got one last question that Corby has been setting up here waiting on. While she's finishing up her question, you guys, we need to go ahead and be shutting down this afternoon. So you guys put it in the chat box if you would like to. We'll try to capture that information. We'll send this to Dr. Martinez, and perhaps maybe when she has time, she can answer some of those, get back with us. We'll put that information out there on our website. And then you guys will be able to, maybe we'll be able to talk her into coming back and doing, you know, maybe spasticity management number 2.0. And we'll have another chance to talk about these things. So Corby, go ahead and ask your question or give us a comment.
Okay, great. Thank you so much. I have HSP, SPG4, very fast developing, worse on the right side than the left. My spine started curving and I had to get a spinal fusion. So I have hardware in my lower back. And I'm wondering if the baclofen pump would be difficult to use with that hardware. That's question number one. Question number two, I got HSP from my dad. My dad's brother, my uncle, also had HSP, but he got ALS as well. Is there a connection between HSP and ALS? I feel that it's developing so fast with me, it's affecting my limbs. I've had to retire completely. I'm on disability. So those two questions.
Yeah. So for your second question, I would have an in-depth conversation with your neurologist about that. Different people have different understandings and opinions regarding the relationship between HSP, ALS, and PLS. I'm thinking it's on a continuum. Some people have differing opinions, so I'll definitely defer to the neurologist on that. Regarding your first question, having hardware in the spine is not a contraindication. You're still a candidate for a baclofen pump trial and a baclofen pump. Again, your physician would need to review the images, but I have seen many patients who have had previous hardware and operations done on their spine, and it's not contraindicated necessarily.
Oh, that's good to know. Okay, thank you.
Absolutely.
And Corby, let me add a little bit more onto the front end of that conversation about what you'd asked about ALS. We know that there are similar pathways between ALS, PLS, and HSP. So those are possibilities. I think that there's an SPG number that also presents itself as being a part of the ALS family. I can't tell you what that number is right now off the top of my head, but I think I had Dr. Fink, I think I heard him say that. So, you know, those are some things that we need to be investigating. We need to be looking at and seeing how similar that we actually all really are. You know, it's only when that motor neuron gets into that particular spot that we actually are morphed into needing to know whether it's a 9 or a 7 or a 59 or a 75 or SPG3, you know, whatever it is. So those are all things that we're all now trying to get our medical scientists, our researchers to help us in explaining how is that pathway and how are those things similar. So stay tuned with us, and we're going to be having some more of these kind of talks as we go forward. But I would really like for everybody to put together your hands and clap, even if your microphones are off. Thank you so very much, Dr. Martinez, for joining us this afternoon. You have got all kinds of love being thrown your way this afternoon because everybody is so pleased to be able to hear that. And I apologize, you guys, that we couldn't get to all the questions. There's always questions. And let me encourage you to never stop asking questions.
Yeah.
Let's get every question answered. Dr. Martinez, do you have any parting words?
Thank you so much for your attention. I'm just thrilled to see all your faces, and you ask such thoughtful questions. I'm just really happy. I'm honored to be able to take this time to, you know, share some of what
I just wrote to her and I said, we're a mile away. You're going to meet us soon.
All right. I look forward to it. Excellent. I'm happy to see anybody in New Jersey, and I look forward to, you know, doing another talk.